Session is medical management. Can you share the screen, please, Venkatesh? Yeah, ready. Next slide. Next slide. Yes. Most important thing next, the most important aspect of this new tuberculosis control program and the tuberculosis elimination program. We call it elimination program these days. We don't call it, and as I had mentioned earlier, RNTCP is not there anymore. We call it NTEP these days. Okay, so NTEP is the one which aimed at eliminating 2020 by 2025, and now they have extended it to NTEP 2030 now. Okay, as we all know, we have two phases, intensive phase and the continuation phase. 4 drugs for 2 months and next slide please. 4 drugs for 2 months and 2 drugs for 4 months. You give intensive phase and the continuation phase. We all should know, though this category regimen is not followed these days, you should still know what the older RNTCP category were. RNTCP categorized that into 4 categories of treatment. The category 1, 2, 3, and 4. And then what they said is category all forms of genitourinary tuberculosis come under category 1 because they all were considered serious illness, seriously ill, extrapulmonary tuberculosis. Earlier, the distinction was that tuberculosis of the prostate, tuberculosis of the fallopian tube, tuberculosis of the epididymis were all categorized in category 3 regime, where the treatment was done with only 3 drugs for two months and 4 drugs and with two drugs for 4 drugs for 2 drugs for 4 months and 4 drugs for 2 months. The category 3 had only 3 drugs for 2 months and 4 drugs for 2 months. That is how it four drugs. Okay, so that was the difference between category 1 and category 3. And then they realized that category 3 is almost useless. So they had made it all category 1 regime for all forms of seriously ill extrapulmonary tuberculosis. And the fourth category was multi-drug resistant tuberculosis, where they had an extended period of treatment given up to maximum of 24 to 27 months. And now the NTEP has completely changed. Although I'll come to that little later when we talk about the various treatment categories of NTEP. NTEP has further simplified that into the 2 categories. That is category 1, that is drug sensitive, and category 2, that is drug resistant tuberculosis. Okay, next slide, please. The next one. All of us should know what the first line drugs, second line drugs are. The previous slide. We should know the first line drugs, second line drugs. What are the various fluoroquinolones that are being used? What are the newer drugs which are available for the ones which are resistant to all the first line? Bedaquiline, delamanid, pretomanid, all these are experimental. Bedaquiline is now available. Next slide, please. Bedaquiline can be a 10-mark question for you. It will definitely be a clinical case. Whenever there is a clinical case discussion, Bedaquiline will definitely be asked when you answer everything else in tuberculosis. All of you should know about this FDA-approved drug Bedaquiline, marketed as Cipturo, and what are the dosage of that, side effects, indications of that, mechanism of action, everything you should know about this particular drug. Read about this drug when we share the slides with you. Next slide. Delamanid, I am not sure, Dr. Venugopal, is it available today? Because this slides show that it is still under phase 3 trial. Maybe at the end of the session, we can ask Dr. Venugopal Reddy again to give a little more clarity about these drugs, Delamanid, Pretomanid. These are still experimental. Maybe you can, we'll get to know from him whether these are available today in Indian market. Next slide.
Yes, sir. Yes, sir. Sure, sure. At the end of presentation, I will definitely will discuss.
Yes. And then the role of steroids, a very common question that is being asked in the exams. What is the actual role of steroids? It's very common tendency for us when a patient with an acute inflammation to put the patient on steroids to get some sort of an immediate response or immediate recovery. The problem with starting on prednisolone is that it's a double-edged sword. The patient can swing this side or that side. Already is immunocompromised. On top of that, if you put the patient further immunocompromising drug, that can sometimes be counterproductive. So there are select indications for starting the patient on steroids. If the patient has got severe cystitis or severe refractory cystitis, not responding to any of the conservative measures, then you can put the patient on steroids. Or if there is a tubular structure that is involved, like ureter, vas deferens, fallopian tubes, if they are involved, then you are justified in starting the patient on steroids, because when healing takes place with ATT being given, the healing occurs with fibrosis. A luminous structure like ureter, if it gets fibrous, what will happen? There will be a stricture, there will be a post-obstructive atrophy, and the kidney will become non-functional. These are the select indications for starting the patient on prednisolone. It's very important for you to know when exactly to start. Severe acute cystitis and tubular structures involvement like ureter, vas deferens, and fallopian tubes. Remember, the dosage that you have to give is as high as 60 milligrams a day in 3 divided doses. 20 milligrams 3 times a day. Also give it for 6 to 8 weeks. Just imagine how much of steroids is actually getting pumped inside the body. That can actually cause more harm than good to the patient. So you have to treat these patients only when there is an absolute indication for starting on steroids. Please also remember this high dosage is required because these patients, when they are on rifampicin, the rifampicin will further reduce the oral bioavailability and the effectiveness of these particular drugs. That's the reason why you may have to give these drugs and triple the dosage that is required. Next slide, please. This is just for you to understand how things started while treating tuberculosis, what were the drugs that were given before, and how the evolution actually took place. 100 years before, this was the drug which was so popular. 1925, if you look at the American Journal of Public Health, there was so much of uh, of importance that is given for the sodium orothiosulfate. They called it a gold cure for tuberculosis. They thought this particular wonder drug gold will cure the patient of tuberculosis. Later, they realized that it is not 100% foolproof. Next slide, please. So what they did was they isolated all these individuals. They put them all in isolation and treated them with adequate gold, gave them good nutritious food to eat, gave them good air to breathe, oxygenated air to breathe, so that the recovery was a little faster. Next slide. So now in the medical management, we'll talk about RNTCP guidelines, the role of DOTS, directly observed treatment short course, and DOTS plus the various medical therapy drugs, surgical therapy, and the special conditions where you have to use these drugs with utmost caution. Next slide, please. This tuberculosis control program, the National Tuberculosis Program, they called it. Before they called it the control program. Initially, they had to set up a program. There is a National Tuberculosis Program which started in 1962. In 47, we got independence. 15 years later, they started this program. They started understanding that this tuberculosis is actually a menace to the community. So they wanted to know a little more about this tuberculosis. So they established a tuberculosis program. Later, they converted that into a tuberculosis control program. That ran for another 30 years. 3 decades later, they realized that they were actually standing at the same place where they had actually started in 1962. In 1992, they had a discussion on what exactly to be done to see whether we can control and slowly eliminate this particular organism from the community. And that is the time when they revised the National Tuberculosis Control Program, called it a National Tuberculosis, revised the National Tuberculosis Control Program. This RNTCP came up in a big way in 1993 and gained more popularity after 1998. The government of India took extreme measures or more aggressive measures from 1998 onwards. And by 2004, they declared that they had actually covered 80% of the country. India is such a vast country with so much of population, 140 crore population. Just imagine how much of crores of population they had to cover if they have to cover 80% of the country with this control program in place. In 2006, they declared that the entire country has been covered by RNTCP. The RNTCP program is such an aggressive program, and they had to take extreme measures in ensuring that the patient actually takes the drug. Some do not take the drug out of fear. Some do not take the drug out of toxicity. Some fail to comply with the standards out of negligence or ignorance. Some will say, this particular organism cannot do anything to me out of arrogance or some sort of an ignorance. They did not take the particular medicine, fear, anxiety, whatever you call it. Ultimately, RNTC realized by 2006 that even though we have covered the entire country, it is not possible for us to convince the particular patient to take the full course of treatment. Just imagine if the patient has to take the drug for 6 long months. Do you think even if you give it free, the patients were not taking? That is the time when they thought they should take extra measures like DOTS program. That is the time when this DOTS program became more and more popular. And then they declared in 2020 that NTEP is not very far off. They said that NTEP should be achieved by 2025. Now they have extended up to 2030. I'm sure that over time, like how we eradicated smallpox, tuberculosis also at one point of time should be eradicated or eliminated from the community. Next slide, please. Next, this I have already discussed. Next slide. Next slide. Next slide. This is where in 2000, early 2000s, this became very, very popular. DOTS. What is DOTS? DOTS is directly observed treatment, comma, short course. It is not a scheme or schedule or whatever. This short, yes, stands for short course. Short course means earlier in National Tuberculosis Program or National Tuberculosis Control Program, NTCP, there was no fixed category of treatment which was prescribed for any of these individuals. Any patient with any patient with TB, each of the general practitioner, whatever they feel is appropriate, they were giving. There was no standardization of the treatment, and until RNTCP came up with specific measures stating that this is the way you'll have to give for. If it is tuberculosis of the epidermis, treat this way. Tuberculosis of fallopian, treat this way. Tuberculosis of the kidney, treat this way. Until then, people were practitioners were treating, physicians were using this particular drug indiscriminately. That is the time when the doctors said, don't have to give it for a longer period of time. You give it a proper dosage. Dr. Srinivasan Ganesan was mentioning a very important point. Give adequate doses of the drug. If you give an adequate dose of the drug, if you give an appropriate dosage, you can just be done with that particular bacteria in 6 months' time. That is what this DOTS was all about. Directly observed treatment short course. They identify a person, a patient who needs ATT, and the government of India, through the primary health centers and through the tuberculosis control centers, they will send their paramedical support team worker directly to reach out to the patient wherever he is. If he is at home, if he is at office, wherever he is, the particular paramedical health worker will reach out to the person. In person, they will hand over the strip or the medicines or whatever and make sure that they take the drug every day. They'll be in regular contact with the patient. In case of doubt, they won't hesitate to even visit the patient every day also. Not necessary in dots, but most of the times they will, if they are not convinced whether the patient will really take the medicine, they will ensure every day that the patient is actually taking. And the next week, medicines will be in person handed over to them on receipt of the empty foil. That means they ensure that the patient gets the next week drug and also at the same time ascertain that the person has taken the previous drug, previous week drug in full. So that is the main objective of this DOTS program. Next slide, please. The DOTS program reiterated the government of India's initiative in an effective TB control. They showed the government of India showed that there's a strong political commitment to effectively control tuberculosis. This particular program, DOTS program, facilitated an active case detection amongst the symptomatic people. Wherever there are symptoms of tuberculosis, they reach out to that place, identify those vulnerable population, identify those who actually need treatment, and then they will initiate treatment with those individuals. That was the key element of DOTS. Then, not only that, once they've identified a person needing ADT, they will standardize the treatment with the first line anti-tuberculosis drugs. That will be under direct observation. Each Anganwadi worker will ensure that that particular patient takes the medicines properly, adequately, and appropriately, and also ensure that there is an uninterrupted supply of these medicines to the individual. They don't want, normally what will we do? We will expect the patient to come to us and get medicines. So in DOTS program, it is the reverse actually. The Anganwadi health worker or sometimes the district tuberculosis control officer himself directly, they'll have a complete list of all the patients in that particular village needing an anti-tuberculosis treatment. They'll have the complete record, means they will know the person individually. Individually, in this particular village, 20 of them need ATT. They will know everything about the particular individual, where he goes, what he does, when he'll be available at home, when he'll not be available at home. Every detail they will know about the particular individual. And then when he is at home, they will directly go there, hand over the medicine, ensuring an uninterrupted supply of anti-tuberculosis drugs. Not only that, they will also ensure that they document whatever they do. They will ensure, yes, today morning I went to this patient Kumaraswamy's house and handed over medicines to them. They will record that and they will report that to their superior, so that the superiors also will know that this particular village, all the 20 patients have received this particular these medicines in full. Next slide. These were the five. Next slide, please. These were the five key elements of DOTS. Okay, the next slide again. All this we have discussed. The main advantage of DOTS is that after DOTS was effectively implemented in the early 2000s, they could actually, the government of India could actually see a higher cure rate, and there is a decrease in resistance also. Again, as Dr. Srinivasan pointed out, if you give the patients adequate dose, appropriate dosage, the drug resistance also can be minimized. And adverse reactions were also effectively monitored. And these patients, when they developed hepatotoxicity, they were identified at a much earlier stage itself, so that the hepatotoxicity can be reversed also. Next slide, please. So these were the main advantages of DOTS. So what is a DOTS plus then? The early 2000s, DOTS was very popular. The same early 2000s, WHO understood that the multi-drug resistant treatments, multi-drug resistant TB bacteria also were so rampant. And then they realized that the DOTS, which takes care of only the first line drugs to be given, was not sufficient. Then they had one committee called the Green Light Committee, which proposed the high quality second line drugs also to be brought under this DOTS program itself. Earlier, the DOTS workers were accessible only for the first line drugs. The DOTS Plus program ensured that the second line drugs are also available, because with increasing prevalence of the multi-drug resistant tuberculosis in the community, they realized that treating the patients only with the first line will not be very effective. We'll still have a few of the leftover multi-MDR TB which are not treated adequately. So these patients also need to be targeted. So they designed a project called Dots of Plus project, which in 2010 to 2015 became very popular in India, which is called Dots of Plus program, where they ensured that Dots of Plus is also available now. Yes. Okay. Next slide, please. Dr. Venu, we will discuss whatever you have mentioned at the end. Okay, fine, thank you. After this program. So then just a comparison between dots and dots plus program, just for the sake of your sometimes the dots and dots plus may be a 10-mark question, for in which case you must talk about categorize what dots is, what dots plus is, all that we have discussed earlier. Please ensure that dots plus takes care of multi-drug resistance, dots takes care of the first line drugs. Okay, first line sensitive drug sensitive microbacterial sensitive to ADT. Okay, next slide.